Good afternoon and welcome to our May quality webinar where we're going to be discussing proactive denials prevention, enhancing quality and financial integrity. Before we get started, I'm going to just go over a couple housekeeping items. We are utilizing the On24 platform, which is a web-based platform. There is no dial-in number, so if you are having any audio issues, check your computer speakers, and if you do a quick refresh, that typically clears out any of the bugs that might be happening. There are several engagement tools that we encourage you to use. Go ahead and ask questions throughout in that Q&A box. We're going to try to make this an interactive presentation, so as you ask your questions, we will answer them throughout the event, and then if there are any questions at the end, we'll ask those as well. Within the media player, there is closed captioning, so if you do need that, you can turn that on. We do have a resources section, and in that section, we have the presentation that you can download, as well as other pertinent resources to this webinar, as well as the certificate of attendance. We do not offer CEUs for these webinars, but you can download that certificate and submit it to an accredited association that you can request CEUs. And then lastly, we always like to know how we did. So at the end of the webinar, please let us know in the survey. So I'm going to go ahead and pass it over to our speakers today. And so again, we appreciate you being here. So Josh, why don't you go ahead and get us started?
Actually, Eric, go ahead.
Hey, good afternoon. Eric Evenson. I work for Solventum. Basically supporting the Rev Integrity business here. Today, we're going to really talk about a number of different things regarding quality and how it impacts denials, how quality, documentation, coding, and the whole process of quality impacts business upstream and downstream. We'll touch on denial prevention, and then we'll really look at solutions that are getting at automating workflows and preventing rework and helping our clinicians move forward with, improving burnout rates and that sort of stuff. So I'm going to start this discussion and then I'll pass it off to Josh. But really what we're talking about is how do we actually get a technology to get from documentation all the way through coding.
Eric, did we lose you?
Can you hear me?
Yeah, we can hear you.
Sorry about that. So my computer is glitching. Josh, can you take this for a second?
Sure thing. So I think if you look at the Solventum approach from capture to code, and this is really what we're trying to depict here on this side, the clinical content and the advanced technology that we bring from basically the start to end. And for those of you that have attended some of our webinars in the past, this is a slide that we're really beginning to use that really shows our clinical content and expertise from sort of beginning to end in all the different parts of our clinical concepts and the models that we bring to the table. So at the top, we're really looking at the clinical content and expertise. And at the bottom, we're really weaving in our advanced technologies. So you'll see some of the advanced technologies that are listed there and really some of the hot topics that we're really hearing in the industry today around conversational AI, generative AI, machine learning. Obviously, ML is definitely a hot topic that we're really hearing about in the industry and what Solventum is bringing to the table. So at the top, we're looking at the clinical content and expertise that we're bringing from all of our different SMEs that we have here at Solventum. And then we're weaving that expertise into the advanced technologies that we're also bringing to the table. So just giving an understanding of how we're weaving the two together to really solve the problem for our customers. This slide here is the capture to code story, and for some of you on the call, you may know Solventum is really the CDI coding quality arm, and really what we bring to the table. But there is much more than that from just what we bring for CDI coding and the Encompass side. We'll really start very much at the very beginning with the speech technology and the Fluency Direct capabilities, both voice to text as well as the ambient technology. So this slide is really meant to depict that we have a complete solution from beginning to end, and we can be that single sole vendor for you to be able to bring all those different technologies together. And then this is really building on that previous slide where I was talking a little bit around the content and the expertise and the technology and weaving it together. And you'll see how that weave really continues forward on this slide, starting with the physician documentation, the different pieces of technology that are available there with speech and ambient through CDI, the clinical documentation integrity, where I'm sure the majority of you are used to using those workflows today, through medical coding, and then really what we're here to talk about today related to payment integrity and quality. So I think Eric's back. I'll toss it to him for the next slide.
Sorry about that. And just one quick note on this last slide here is we all understand that the whole process of quality is at every single step in each of these phases. And if you look at the lower part of this diagram, quality can be impacted and have interdependencies between multiple of these steps, sometimes not linearly, but sometimes together. So we'll touch on that a little bit further this afternoon. One of the things that we are finding challenging with several of our customers right now is that there are so many discrete data fields and elements of looking at quality as it relates to documentation, as it relates to coding, and then specifically as it relates to preventing denials. There are data elements in each of these different sectors, from case management to physicians to CDI, coding, and even in the back office. And one of the things that we're looking to do is to try to streamline these data elements and make sure that the information is captured and put into the workflow at the right place at the right time to prevent a denial and improve quality from the very beginning. One of the questions that we wanted to talk through today as we're getting into this discussion is, where are you currently seeing the most clinical validation denials in your organization? How often are they tied to documentation, quality of care, rather than actual clinical care? And so this is a question. If you guys can click this, we'll wait for a few of the responses. And while we're doing this, just a quick note, we would love this dialogue today to be interactive. So if you guys have questions throughout, please note the questions in the Q&A box. And Josh and I will take these questions as they come up. All right. So here are the responses. It looks like most of the time, the highest percentage, sepsis and respiratory failure are linked to quality issues as well as denials tied to documentation gaps. This is very consistent with what we're seeing across a lot of our clients. Malnutrition, encephalopathy, documentation related around that, and then heart failure and kidney injury, CKI, which is also very interesting. It's amazing from a quality perspective how far we've come with heart failure. 15, 20 years ago, before Get With The Guidelines came out, everyone was having issues with heart failure. And now it looks like it's still an issue, but not necessarily the highest issue that you guys are all having from a clinical documentation perspective. Josh, you want to make any comments on this?
No, I think you covered the hot topics there.
So denials really are not just financial setbacks. They all stem from a whole bunch of different things, mainly from coding and documentation gaps, clinical validation issues. Even upfront, clinicians may not even capture all of the medical necessity criteria in the review of systems that goes into their documentation. And so what we're really seeing in the market today is inconsistent documentation, clinicians not capturing the total burden of illness of patients. And so you see that there's comorbidities or complications that are not captured or documented. Sometimes, from a MS-DRG perspective, there's not a CC or MCC documented. Even chronic conditions that are not captured in a specific encounter that would contribute to a higher severity of illness for a patient. And then addressing root causes can really help with these types of things. As you guys know in quality, documenting a patient's complete burden of illness really impacts the observed to expected rates for all of your patient safety indicators, your HACs, and specifically your readmission and mortality measures. And so the higher, and you guys know this, but the higher acuity of patients that you have, the patient mix that you have, the higher expected amount of your facility having a PSI, a HAC, or a readmission. And so those observed to expected rates can, if you're not capturing the correct burden of illness of all of the patients, it can really impact your quality scores. So one of the things that we kind of want to talk through today is that doing things of how we've always done them in the past is not going to work going forward. We have major resourcing needs on every single organization's level, not only on the clinician side, but also on the business and back office side. And so if you look at denials, working denials, if you look at root cause analysis regarding quality issues, if you look at revenue leakage and all of these different processes, there are several people within your organization that are supporting the patient account and the clinicians at every step of the way here, all the way up through the reporting and analytics and following up from an encounter that was denied. So one of the things that we would like to address is how can we actually move and automate a lot of these processes upstream. So instead of managing denials on the back end retrospectively through finance or using work lists and that sort of thing and doing root cause analysis, how can we actually proactively prevent denials by making sure that medical necessity criteria, that making sure that clinical coding and documentation is correct in visit or pre-bill before the bill is submitted, or even all the way upstream until you get into a in-visit type approach. So one of the things of moving this upstream is really how do you actually identify trends in your organization that you have and where do you start? So one of the things that we're looking at is using artificial intelligence and machine learning to look at predicting denials, really understanding denial patterns from payers, and getting that intelligence into the revenue cycle workflows to provide more precision when you're capturing the severity of illness and risk of mortality in your documentation. And the other some of the other things that we're really looking at is how can we actually get into your workflows and provide real-time feedback on clinical quality measures or coding, things of that nature that might actually put a case into a negative quality outcome case. For years, many of your organizations have been doing this with the POA status, for example, the present on admission status. So you have automatic checks and balances within your EMR that when a condition is labeled as not present on admission, you guys review that case before the bill goes out. This is something similar, but much more advanced when we're using a natural language processor to really comb through the record, not only in the encounter, but in the past record of the patient, and make sure that we're capturing all of the documentation up front. And then more specifically, the other kind of thing that we can do upstream is look at payer rules. Payers have a lot of different auditing technologies, and they have rules on if they're going to deny or approve services and that sort of thing. And one of the things that we're actively working on is how do we get some of these payer edits into the workflows to make sure that the documentation and the patient severity of illness matches what the patient is there for and is not going to contribute to a denial on the back end. Any questions so far? Another question. So how often do your quality measures like severity of illness or risk of mortality get impacted by insufficient documentation or misaligned coding? So frequently, sometimes, rarely, or not sure. Wait a couple more minutes. Right. Looks like frequently. So most of your organizations actually have a reoccurring issue with insufficient documentation for severity of illness or risk of mortality. And it's interesting here, some of your organizations haven't actually looked closely at some of these measures. That seems quite high, but it also could mean that that function is occurring elsewhere in your organization. This is quite just a side note here from a quality perspective. This is what we're seeing increasing in the marketplace today. The other impact of not documenting the correct severity of illness or risk of mortality from a quality perspective is after COVID, we're seeing many organizations have increased length of stay. And the reason, part of the reason of the increased length of stay is during COVID, everyone got the COVID modifier, which increased the expected length of stay for a lot of these patients. In late 2022, early 2023, when that modifier went away, the observed to expected length of stays for each DRG went back to normal, and organizations did not adjust their practices. And we're seeing the results of that now. We're going back to insufficient documentation and perhaps not capturing the burden of illness of the individual patients, and therefore having a higher length of stay than expected for many organizations. So revenue integrity challenges are ubiquitous through the entire market. And it's not just the US healthcare market, but it's globally in healthcare markets around the world. One of the biggest things that you guys have probably all seen documented many times, starting in early 2000 when To Err Is Human came out, and several studies since, but it is now estimated that about 25% of all healthcare spending is considered wasteful. And about 1/4, so that means that, you know, 1/4, essentially 1/4 of all of the interventions that we provide to patients are not necessary and or do not contribute to improved quality. In the last couple of years, on an annual basis, it's estimated about $10.6 billion was spent overturning medical denials. So that challenging the insurance claim disputes, re-adjudicating claims, many things like that. This is both from a clinical quality and from a financial cost perspective. You think about clinical quality in the fact that if you don't have medical necessity criteria documented, or if you have a condition that was not labeled correctly, you're going to have an adverse outcome from a quality perspective. And so some organizations actually choose to rebill or re-adjudicate some of these encounters if they don't have that correctly, because it'll impact them downstream. You know, right now for Medicare, you still have a withhold, or you get dinged on readmissions. For your HACs and PSIs, you get dinged on future revenue. And so what you're doing today will impact your future revenue of your organization downstream, and it'll stay with you for 18 to 24 months. You guys all know this. The other thing is that recovering the payments, not only the payments, but also the quality measures, takes a long time. So from a financial perspective, when you're re-adjudicating claims, it can push out the financing piece of it 6 to 12 months before your organization can see some compensation regarding correcting documentation. And more importantly, from a quality perspective, as you guys know, the measurement period, even though it's a year, the reporting period is 18 plus months, especially with CMS. And so what you're doing in your hospitals and in your clinics today from a quality perspective is actually going to stay with you, sometimes for multiple years until you can correct that. And then the other piece here is that it's estimated that DRG validation, so correct and appropriateness of the DRG, is estimated to have an opportunity about $5 to $10 million. So either DRG downgrades or DRG changes, missed query opportunities, findings, and that sort of thing, actually has a pretty large opportunity in the market today. I will pass it off to Josh.
So I'm going to take it over from here and talk a little bit about the Solventum approach as well as our product. This is, for those that aren't aware on the phone, this is one of our newest technologies and solutions that we have brought to the market. It was officially, I would say, launched at HFMA in June of last year, but really focusing on what a denials prevention solution should look like. And I would really focus on the prevention side. I think what we've heard from a lot of customers is that it's a different type of school of thought. And, we're really looking at being able to solve the issue that is at hand related to a potential denial while the head is still in the bed or in that pre-bill space before the encounter or claim actually drops to go to the payer. So with the approach from Solventum, we're identifying identifying and helping to prioritize those encounters where there could be a risk for a denial in the CDI workflow, in displaying a denial risk sheet and identifying those potential issues, as well as being part of prioritization that became available in the 25.2 release. And then in the coding workflow, in our pre-bill solution, being able to identify where there could still be DRG validation issues. So those are the two workflows that we're going after and focusing on. I'll talk a little bit about them in some future slides, but then in addition, providing the root cause analysis and analytics around trending. The previous slide that Eric talked about, we want to make sure that the clinical resources that you have in place are being most utilized where appropriate as it relates to being able to prevent the denial before it actually happened. So how to address revenue leakage proactively? I would say these are the three approaches that we're taking from the Solventum aspect. One, the revenue integrity intelligence. I'll talk about that as well on sort of the next couple slides, but providing and aggregating the data both from the financial side and the clinical side to be able to give the deeper dive as to where some of those trends or some of those pain points may be. The second part being immersive machine learning, using the ML, whether that be through natural language processing, which some of you probably are used to using in the coding workflow, versus natural language understanding. For those of you that are using our CDI Engage 1 technology, that is something that you're probably used to hearing, but basically using our ML to be able to identify where some of those risks could be related to the denials. And then third being the curated actionability. In my role being the business manager, I want to make sure that whatever we're showing an end user is just not something we're showing to show. We know that alert fatigue is real on the physician and provider side. The same holds true for CDI encoding. You guys are being shown a million different ways information within the technology, but we don't want to show something if it's not going to drive value. We want there to be able to be an action that's able to be taken based off of what is being shown to you in your workflow. So that's the approach of how we're looking to address the revenue leakage. From a data standpoint, in an ideal revenue integrity solution, for those of you that attended the CDI webinar series last month that I presented on, some of these slides are a repeat. If you've attended other webinars that I presented on, you've heard me talk a lot about this slide here. This is sort of the slide of what I would say is like our secret sauce, how we're getting to the ability to prevent and identify those encounters that could be at a risk for a denial. In the green section, that clinical inputs circle, that is data that's the Encompass today. We're really capturing your CDI and your coding data points. Right now, we're sitting at about 140 different data points that we're pulling out of 360 to be used in this preventative solution. In the blue circle, the financial outcomes. This is your 835 and your 837 data, so the claim going out to the payer and the adjudication coming back, as well as the EMR data. And really with the EMR data, we're focused on the accounts and transactions because we want to see what happened to that encounter at the end of the day. What happened to that claim? Did it end up being a DRG downgrade? Was there a take back? Did you end up writing it off? So those are data points that obviously we don't have in 360 today. That's not in your 835 and 837. So that's why we're pulling out of your electronic medical record, or in some instances, maybe your financial system, to be able to see full circle, really what was the end state of that encounter. Now, to build the predictive model in being able to identify those encounters, we want 2 years of your historical data. So 2 years of all 3 areas of the data that I just mentioned. And then simultaneously, while we're getting that 2-year historical data, we will be setting up a regular feed so that we're constantly feeding the machine learning. The thing to point out here that's important, and a question that I get asked by a lot of customers is, well, do you need my payer contracts? And we actually today, for the way that the solution stands, we don't need your payer contracts because we're building the model specifically for you based off of your experience with the payers. So we're seeing how these payers have reimbursed you for those specific DRGs based off of that clinical representation of those encounters. And that's how we're really using that in the model to be able to predict those encounters with the high probability of a denial from happening. So not to say that in the future, we may not want your payer contracts and we may not be looking to see them. But for right now, the way that the solution is developed and focused on, we don't need that. We're able to gather the information directly from those 3 buckets of data that I sort of mentioned. The other thing that I want to point out is that I don't want to discredit any IT lift to the solution. This doesn't require, it requires one interface at this point, an ADT feed, but we're not building all brand new interfaces to get this data for you. The clinical inputs that's coming out of 360, that is something that Solventum will take on from our implementation team to be able to get that data. Unless you have a 360 administrator that is very gung-ho and wants to pull this data for us themselves, that's completely fine. Otherwise, we'll take that lift on from the implementation side. The financial outcomes, that data, that would be the lift on your side. And that's something that I don't want to discredit. And normally when customers ask me, what is the lift here? And I tell them, well, it's the lift is going to be you to be able to get us that data. Some customers seem to be able to get it very fast for us. Other customers, it takes some time. So it's not a whole bunch of new interfaces that need to be built, but really focusing on the data and making sure that we're talking to the right team members to be able to get us the data in a timely manner. So I have another poll question coming up here. Do you have visibility into which diagnoses or service lines are most prone to denial before claims are submitted? So I'll give a minute here for those to answer the poll. Give it just a few more seconds. So it looks like actually a no we usually find out after the denial happens at 32.7% is the highest one there. And I think that obviously that's important, at least from the Solventum end. So if you think about, and actually, it's actually a good point into the next slide, so I'll just sort of jump there. If you think about the Solventum approach, this is sort of explaining it in the 2 phases that we're going after. That first phase, enhanced denials intelligence, that actually goes back to the poll answer of seeing, no, that's the problem that we want to solve for you. And being able to focus on the enhanced denials intelligence, we're taking that data aggregation that I explained prior to the poll question, and we're being able to look at where are your trends falling, where are those pain points, what are some of the specific DRGs that we need to focus on, what are some of the specific service lines we need to focus on. In the next slide, I do have an example of some of that information of where we're really going to be able to give that granular detail that we've heard from a lot of C-suite executives that they're looking for. If you think back to the busy slide that Eric talked about of where data is housed in multiple different places, that's the silo that we're really looking to break down and give customers where denials are happening across the system. CDI may know only what they know based off of the reporting that they're responsible for. Coding may only have an insight for what they're responsible for, but they have no idea across the whole health system. And that's the silo that we're really looking to break down and the problem we're looking to solve for our customers. In the second approach, the integrated workflow intervention, it's really going to be dependent on what is the problem that, or what is your pain point that we really need to go off of immediately. Do we have to, let's say, I say do we, but should we focus on the CDI workflow? Or is it that in that pre-bill space, when final coding has been completed, but the claim hasn't been dropped yet, do we have to focus on that area? We know through customer conversations, there's a lot of vendors that are in that pre-bill space that are doing a lot of that work right now. If we go back again to sort of the capture to code slide that I talked about at the very beginning, we want to be that single vendor for you and that single platform that we're able to solve that problem across the continuum of care for all of our customers. So the integrated workflow intervention for CDI, again, in prioritization, as well as showing the denial risk sheet of where some of those contributing factors or issues may lie. For those customers that are using our CDI Engage One technology today, the denial risk sheet is in that same infrastructure and in that same view within 360. So if you've been exposed or you've seen our CDI Engage One technology, it's all housed there from a CDI standpoint. For coding, again, we want to focus on the pre-bill, final coding before the bill has dropped, and if there's still potential issues that need to be resolved, going to, let's say, a second level review for resolution before the claim actually goes out the door. So those are the two approaches, or the two, I should say, phases in how we're looking to really implement the solution from a proactive standpoint.
So we do have one question, and that is, so why are denials so important to coding and CDI in their day-to-day? I think, Josh, you just kind of explained it in this diagram here.
Yeah, I think the important part is that our approach is if you have a end user reviewing or doing something already. So for example, in CDI, if you have a CDI review already occurring, while yes, there may be a contributing factor that is showing to the CDI that he or she is not responsible for, through people process technology, we want to be able to help resolve that issue while they're in that actual workflow. So looking at, again, at shifting the resources or the eyes and the focus as to where that could potentially be resolved while the patient is still admitted. So looking at the actionable insights in that phase one, or the enhanced intelligence, this is an example here of what we would be delivering within Encompass Analytics. For those that are not aware, this was sort of a name change. It just happened from Enterprise Analytics to Encompass Analytics. So if you hear of us say that, that's what we're talking about. It's all still the same platform, just a slightly name change. But here, this will be dashboards that will be available to really give you that granular level of detail. I'm not actually showing all the different dashboards that would be available, but this is giving an understanding that, okay, you're going to be able to take that data aggregation and have an understanding from a CDI standpoint, where did a CDI review happen and a denial still happen. So, was there a query sent and was it agreed and documented, but a denial still happened? What are specific DRGs where denials are happening? Are they medical or surgical patients? What are the specific length of stay? At the top here in this sort of Excel, if we would have expanded that out, you would see specific DRGs that are under there. We're going to be able to give you down to the granular level of who is the actual provider themselves that a query was sent to and maybe a denial still happened. You'll be able, if you're a health system that has multiple facilities, you'll be able to look at the health system as a whole versus looking at specific facilities. Again, using Encompass Analytics to get you to that granular level of detail. So using immersive machine learning, and I see a question that just came in about inpatient denials, or does it help on the outpatient as well? So for right now, the solution is focused on inpatient denials with the goal to get to outpatient. Now, in that phase one of the enhanced analytics, if you send us your outpatient 835 and 837s, that will be included in the data that is presented. But from a workflow standpoint, in sort of this slide slide helps cover it as well, where we're able to do those integrated workflow interventions at this point. We are focused on just inpatient, but not to say that we're not going to start to look at ways to blend into potentially our outpatient CDI platform, or as well as looking at ways to, if you're a customer that's considering autonomous coding, what this could look like from an autonomous coding standpoint. But for right now, we are truly focused on inpatient denials. So infusing across the revenue cycle, if you look at the circle, and I covered a little bit about this already, in the denials prevention, I mentioned CDI and coding. We understand that there's a desire and need for utilization review around medical necessity. This is a silo we're trying to break down. We know that the UR workflow primarily sits within the electronic medical record. But right now, some of you may have had discussions with our user experience team where we're trying to receive some feedback where if we would create, let's say, a specific swim lane within 360 Encompass that would be, let's say, only read-only, can we show information to a utilization review nurse that could say, okay, there is a risk for denial here. This is the reason that the denial is happening. And if it is for medical necessity, sort of give them the idea of where they need to start or what they need to be looking for related to medical necessity. UR is on our roadmap. I think it would probably, be delivered at the beginning of next year, but it has been something that, we know that there's a desire for having utilization review included in our solution. For prioritization, I've talked a little bit about this already in the CDI workflow being an additional priority factor. This can be a priority factor for a standalone swim lane, or if you want this to be a priority factor incorporated into your CDI prioritization, that is also available. So we want to make sure that we're delivering those real-time recommendations for intervention in the mitigation of where those issues may fall. And then in the previous slide, I already talked about it, but really giving you the detailed insights and analytics as to where we need to focus. We know, and payers are using AI today. But with our solution, we want to be able to provide our customers with the trends sort of a little bit ahead of the curve from where you may be seeing them starting to come in from the payer. So we want you to be able to be, I would say, reactive a little bit faster than sort of seeing it much further downstream whenever you're already starting to see the payers make changes. We want you to be able to see that in your data. I understand, I hear it a lot of times from customers already. Well, if we fix one issue, the payers are going to start to see something else and they're going to go after that issue. Well, we went through our detailed insights and analytics. We want to be able to provide to you to be in reporting to stay ahead of that. So yes, maybe you do resolve one issue and then they'll see the next shiny object to go after. We want to be able to provide you that level of insight that you're able to go after that shiny object as well. Now I'm going to talk a little bit about actionability. I didn't, want to focus too heavily on sort of the workflow and the solution here, but I wanted to give an idea of what this would look like from a preventative state. So this is, I know there's a lot here to cover, but this is right out of an example that we saw in a customer's data. So this was a short length of stay, only 2 days. The auto-suggested MSDRG was 291 with the final MSDRG of 291 as well. There was no CDI review done and there was no query sent. It was likely because in many instances, only being a 2-day length of stay, this wouldn't have necessarily hit, let's say, a CDI's work list. You'll see on the right-hand side the final code set. This is the final code set exactly as it is. We did not do anything to it. So in using our CDI platform and incorporating that actionability from a denial standpoint, you'll see in the green box the CDI opportunities. If using prioritization appropriately, as well as coupling it with our CDI Engage 1 technology, we would have anticipated that a evidence sheet and prioritization would have been caught for the type and acuity of heart failure, as well as asking for the clinical validation of the respiratory failure. So those two reasons would have caused an evidence sheet to fire. Then on the left-hand side, adding in the denial piece, we would have flagged this for a high risk of a denial from happening. And we would have identified that that the patient is in the incorrect DRG for the current length of stay, as well as we would have identified those clinical validation issues related to the respiratory failure and then the unspecified heart failure. So in using the CDI Engage One technology, coupling it with the revenue integrity solution and the preventative approach, that's how we're sort of blending these two together to work hand in hand and side by side. The most important piece here, and these are just all examples, so please do not hold my feet to the fire in these examples, but really here we know that ROI is important. We understand that budgets are very tight. Those that are responsible for signing the check, they want to see really where's the ROI going to fall. So in the preventative approach, and I would say let's focus on the improvement section, we would hope to see a reduction in the denial rate and obviously the denied dollars. Then we really want to look at what has been avoided. So what denials have been avoided as well as the dollars that have been avoided. In looking at the drivers, those go back to what do we want to really focus on, and using, I would say, those trends in those focus areas. So is it back to that example I just talked about, is it that we have to focus on short stays? Yes, maybe that's not a traditional patient population that CDI has gone after, but it has a high risk of a denial. So looking at certain drivers that we really have to focus on and to really drive that value. So looking at the reduced short stay, again, some of those medical necessity issues or concerns, having fewer of those. And then we know that the surgical denials are on the increase. You might have an authorization for a planned procedure, but that wasn't the performed procedure. And then the time is ticking to get that auth updated for that surgical procedure, and that window is very small. So those are really drivers that we're looking at having an impact against as it relates to the preventative solution. Example possible impacts for hospitals. We know that you could see an initial drop in denials and improvement in your CMI within 6 months. We know CMI is very important. We want to focus on improved O to E ratios, obviously looking at where we can make improvements in the clinical validation denials. I will say for those of you that are in the CDI realm of things, clinical validation denials, and what I hear from some CDI departments, and some of you may disagree or agree, when we ask the question, what role do you play in denials? Some come back and say that they don't play a role. But then when we start to take a little bit deeper of a dive and we ask, well, if there's clinical validation questions or denials that come in, are you not answering them? And more times than not, the answer is yes. So then my answer back is, well, then you are playing a role, but yeah, maybe you're not the frontline staff that's playing a role in the denial, but you're helping to resolve that issue as it relates to denial. So we hope to see through using a preventative solution that there's improved documentation with the reduced of clinical validation denials. So the last slide.
Sorry, Josh. One quick note there is the other piece of what we're trying to leverage the AI and NLU technology is really determining trends, especially if you're having multiple adjudications for a claim, especially in your complex patients. So think your diabetic patients or your heart failure patients that have multiple encounters. Or your oncology, your cancer patients, where if the documentation and medical necessity criteria isn't set up front on the initial encounter, there might be subsequent encounters that are denied. And so the NLU and AI will actually show you guys some insights into how each of these adjudications, what the interdependencies are, as opposed to having to do this manually. And look at them retrospectively. So that's one of the benefits to a coder and a CDI professional.
So I'm going to get to the last slide, and while I do that, feel free to please put questions in the chat if you have a question, but really, where can you start today? The first one is the cross-team functional collaboration. And why this is important is because we have had customer conversations and been in conversations where we may be talking to just the CDI, the coding, or even quality, and they really don't have an understanding as to what technologies, solutions, or workflows may be happening in the revenue integrity or rev cycle side related to those. So having a small focus group of all the different departments that could be playing a role, again, back to the slide that Eric talked about at the beginning, where there's multiple different workflows that impact denials, that's very important so that everyone can hear the same conversation. Even though everyone's trying to solve the same problem, it seems like there's different paths to solving that problem. And we've seen where maybe there's not always an understanding of what's going on across the full health system. That bleeds into the technology and data review, again, having understanding of what vendors are in the certain spaces today, how they're being used, maybe where there could be a lack of technology or services to be able to deliver and solve the problem. Having a better understanding in those conversations is very important. And then lastly, the write-off analysis, understanding, and maybe you don't have that level of understanding today, but understanding the financial opportunity related to the preventative denials. Obviously, that's something that Solventum will bring to the table in being able to implement that phase one. But if you're able to have that write-off analysis completed, that obviously will help in conversations as it relates to a preventative solution. So with that, I will turn it back over to Lisa.
Great, thank you both. This is a really great presentation and a lot of great information. And so, for those of you that have asked, we are recording today's session. We will be posting this to our website in the next couple weeks. So definitely you'll want to listen back in to get the information again if you want to. So because we're getting close on time, I am going to just ask one question that we have, which is, clinicians are burned out. How can you prevent denials without adding more to their plate?
Eric, you want to take that?
Yeah, sure. So I think I kind of alluded this to the very beginning, is using how we're leveraging AI and machine learning to really look at trends and match rules, payer rules, medical necessity rules, and all of the guidelines up front. Our main goal is to really come upstream and help clinicians change behavior so that we're not doing rework on the back end. Part of this whole process is really helping clinicians reduce the number of queries, the number of adjudications, and that sort of thing. And so in the end, we are really trying to automate a lot of the administrative back end, which will in turn create time to care, not only for the physicians, but also for nurses, coders and CDI folks, so they can focus on other problems as opposed to redoing encounters or claims that got denied.
Great. Another few questions that we did get was around the resources. So don't forget, before you do close out of the system today, make sure you do download the presentation as well as the certificate of attendance. You can utilize that to submit to an accredited association for CEUs. If you are interested in learning more about our solutions, there is a contact me button in the middle of right under the slide section. So if you are interested in having one of our representatives contact you, let us know there. We are excited to announce that July 21st through the 24th, we have our Solventum Client Experience Summit. So if you are one of our current customers, we would love to see you there. Within the resources section, there is a link to learn more information where you can register. It's at the Swan in Dolphin Hotel. It's beautiful. It will be a little hot in July, not going to lie, but it will be a great program that we're going to be putting on. We also are offering our Solventum Educational Boot Camps. There is also the opportunity to register for those in our resources section. So whether you're interested in advanced CDI, advanced quality, or advanced CDI pediatric, if you're interested in learning more, click on that resources section as well. So again, we really appreciate our speakers who joined us today, as well as all of our attendees. We thank you so much for joining. If you are interested in learning more about our solutions or our upcoming webinars, you can also find that in the resources section. So hopefully you'll be joining us again. And again, thank you to our speakers, and let us know how we did in the survey. Have a great day, everyone.